Hello. Today I will be talking about agitated children and aggressive children regarding the adolescents as well as children. Why this is important? Because it is very dangerous and it can be very stressful for the caregivers as well as for the families to come across with an agitated and depressed child or adolescents. This may also discontinue the services in hospitals, and also it may require some physical limitations as well, especially for the youngsters who come to the emergency wards for this reason. Because of the detection, because of the fixing. So this, in order to decrease these physical limitations like fixation, is there a common understanding for this? And there is no standard guides on this. This is what I have seen in the studies. Only in 2018, a group of psychiatrists and pediatricians and psychiatrists came together and related to the agitation, management of agitation in adults. Accordingly, they were inspired by this, and accordingly, they formed a kind of guide. And according to this guide, in emergency cases, to be dealing with agitation, it should be multidisciplinary and individualized, and it should depend on the cooperation and the clinicians. And in meanwhile, sorry that I missed to continue with my slides because of my excitement. And the clinicians should adapt to understand the etiology factors leading to agitation. And first of all, in order to decrease the tension, they should use non-pharmacological strategies to de-escalate. And accordingly, they should hear about the episode of the patient. For example, if we consider an autistic child applying to the emergency, it may be that the child may be affected by the fluorescence in the room, and that requires to take that child into another room, and the agitation can be decreased by certain interventions. In many cases, addressing etiologic factors proactively and non-pharmacological can obviate or completely eliminate the need for pharmacological interventions. And etiology drives choice of treatment. Diagnostic assessment occurs in parallel with symptomatic management, and the patient on one side is being intervened, and the other side there are additional information to find out whether there is any change in mindset and the mental response and symptom responses, and these are certainly contribute to the evaluation. Unfortunately, there is no evidence-based scale for this assessment. So for that reason, a psychiatrist should have a careful assessment, the psychiatrist as well as the pediatrician. It's very important that they make this very carefully. The members of the family prior to the disease, related to the developmental process, they provide information to the health professionals. It's very important, and they help to understand us, to make us understand the reason for the agitation. So if we make an assessment of the etiology, why the child has become agitated now, and here are the antecedents such as environmental or interpersonal triggers or internal stressors such as pain or acute psychiatric symptoms. These are the things that we question. And apart from this, we learn about the psychiatric history, whether there's medication or any allergy or toxic ingestion or past medical history, developmental history. So even though it's hard to do it, if it is possible, we ensure a full, complete examination, and also we try to get the laboratory imaging of that patient as well. If the reason of the agitation is not known, if it is complex, then the clinician would judge as per his or her own in knowledge, and then accordingly an intervention can be performed. And agitation is a symptom like pain with many potential etiologies and often multiple factors contributing in the moment. And for example, the potential etiologies for acute agitation among youth in the ED physical disease may be pain, delirium, intoxication, and catatonia, and they may be the reasons for these agitations. For example, if there is a psychiatric problem, that the reason for agitation and aggression, it might not be the reason for this psychological problem. It can be a physical disease or an anxiety or another acute trigger, and we have to discard these. And non-pharmacologic approaches used for de-escalation should be employed early with a preventive and proactive approach. So, what are the non-pharmacological management? The first one is to prevent and de-escalate agitation, and as primary prevention, it includes changes to the ED environment to make youth more comfortable, clear communication to reduce anxiety, and effective assessment and treatment of pain and other acute physical symptoms should be fulfilled. And as regards the secondary prevention, it includes modification for youth identified to be at baseline elevated risk for agitation or for youth beginning to show signs of agitation. So what can we do, for example? It may be the calming strategies that have been effective in the past, and also an agitated should be moved away from other patients to calming, safe area without access to sharp and dangerous objects. And as mentioned by Ms. Moussine, it's important to communicate in a neutral yet empathetic tone and to communicate at the patient's eye level. And if the family is a triggering item, then they should be moved away. And also, we can use clear, concrete, and simple language, and we can use non-pharmacological methods. And we should not forget that in the emergency ward, even though a young is agitated a lot, then this non-pharmacological strategy would certainly be helpful and effective, and accordingly, these non-pharmacological methods should be used with the medication as well as alone. And when we talk about the rationale for medication use, there are two aspects here. One of them is the target, the underlying cause of the distress, and these are the interventions for etiology. And secondly, the calming the patient sufficiently for rapid assessment and treatment. What does it mean to calm as much as required? So it means that the medication should be calming but not excessively sedating. As a youth who is asleep cannot be evaluated, participate in care, or leave the emergency department. And also medication should be chosen for its calming effect, but also to address the underlying etiology of the youth's distress, so that not only one medication will be appropriate for all patients or all types of agitation. So if we just talk about the general recommendations regarding medication use, a current medication history helps to avoid drug interactions and adverse drug events. It will certainly keep us awake and alert. And often a half dose or extra dose of home medication can ameliorate escalating agitation. And for all the patients, there would not be only one solution, one fits all. And, and unfortunately, there is no evidence on that. And if it's possible in medication first, we have to go for the oral medication. And if there is an intravenous instead of intramuscular IV, through IV, we may administer the medication. Diphenhydramine is an antihistaminic. There is a benign adverse effect, and especially in the younger children with the mild to moderate anxiety can be up to. However, if there is a doubt of dilorubin or paradoxal inhibition, or an expectation for paradoxal inhibition, for example, like the autism spectrum disorder children, we should avoid benzodiazepines and diphenhydramines. And in the cases of severe agitations, for many reasons, for many causes, we can consider neuroleptics, and the total dose should be followed closely. Olanzapine can potentially be sedating the haloperidol or zisperidone and has less risk for cardiac adverse events or extrapyramidal symptoms. And olanzapine, what we have to pay attention as the most frequent ones are the olanzapines and benzodiazepines, and they should be administered parenterally within 1 hour of each other because there is risk of respiratory suppression. In children, there is consensus that if an initial dose of medication was ineffective, a second dose of the same medication is preferable to adding multiple different medications, as children can be vulnerable to drug interaction adverse effects. An exception to this one is combining haloperidol and lorazepam, which was generally considered preferable to a second dose of a neuroleptic in non-delirious patients. The etiology of agitation should be reassessed continuously, especially after 2 doses of particular medication, and you who have received multiple doses should be monitored continuously. And total daily dose or not to exceed instructions should be written, and cumulative doses monitored, lest akathisia, delirium, and iatrogenic syndrome such as neuroleptic malignancy be misperceived as worsening everything. There is no concept that ketamine and barbiturates are not recommended for treatment of agitation, and that opioid analgesics should not be used in these cases. So, considerations when selecting psychotherapy for acute agitation management. So, there are certain points to be taken into consideration. For example, when the formulas available, onset and duration of action, presence or absence of active metabolites, interactions with other medications the patient has received in the emergency room or takes at home, metabolism and excretion, potential side effects or other drug interactions. So related to patients, there are certain factors for choosing the drugs. For example, etiology or etiologies of agitation, routes of administration available, GI functions, nutritional status and physical size, hepatic function, renal function, other comorbid physical health concerns, and patient preference, as well as the family preference. And also, there are also system factors. It means that training and experience with non-pharmacologic approaches to agitation management and with use of different medications for agitation. comfort of other work providers with use, monitoring, and management of a given medication, and also availability of monitoring practices within the care setting and hospital system. And these are important for choosing or selecting the appropriate drugs. So I will not talk about this scheme in detail. In this table, the most frequently used doses of the drugs, as well as the summit effect or the peak effect of the doses, or the factors to be or monitorized, or the effects to be monitorized are summarized within this table here. So this within this guide here, there are some specific subtitles are taken in are tackled one by one, and which drug intervention should be used for which agitation cases. So unfortunately, there might not be only a single etiology for agitation, or it might be the case that it is not understood in terms of the cause. A patient with a bipolar disorder, the adolescent may be drunk, but the aggression reason cannot be differentiated, whether it is due to alcohol or whether due to its bipolarism. So for example, an autism spectrum disorder child can be in delirium, and the aggression reason cannot be very easily understood. And in such complex cases, the one who works in the emergency ward should take into consideration all emergency facts and aspects, and these should be evaluated, assessed well, and then the clinical judgment should be made, and accordingly an intervention should be made. And the first subject is on the agitation related to delirium. Your last 5 minutes. Thank you. So, in delirium treatment, we first have to understand the underlying effect and whether there are drugs causing delirium. We have to stop them, and also if there are ache and pain and upset stomach, and we just avoid the sedating agents, and we support the sleep, and we can also give melatonin to support the sleep, and from which in delirium, which we avoid anticholine and quetiapine or analgesics, and then benzodiazepines and atypic, so neuroleptin, atypic antipsychotic. What is the duration of action? We make our selection accordingly. If we want to avoid neuroleptic, the chlordine may be used, but in child psychiatry, we do not use it very much. And the second reason is that agitation depends on the use of substance. First of all, if we know the substance which causes intoxication or for withdrawal, we can intervene accordingly. But if we do not know what the substance has been taken in severe agitation and hallucination, then haloperidol can be used. And for agitation, dependent on the lorazepam, can be a secure and safe option. And if a child has a delayed development and OCD, and then these children are more sensitive to the adverse effects of the drugs. And first, we have to discard the physical problems. For example, we have to make the interventions accordingly. We want to understand this situation in a silent and peaceful. We have to keep the person in a silent and peaceful environment, and also we ask the experiences of the parents in terms of the adverse effects, and if there are drugs already being used, we may prescribe extra additionally, and this may prevent the agitation, and intramuscular treatments should be avoided. And in acute psychiatric, when we look into the agitation in emergency, the patient with psychiatric diseases, one of the most common is that the patient keeps taking the drug. So for that reason, that missed dose or to give the patient as a whole dose may help, and it may be the case that there might be other reasons for agitation, like pain, for example, or substance use. In pre-adolescent group, mania and psychosis is very rare. If there is hallucination and delusions in agitated condition, before mania and psychosis, we have to talk about delirium and catatonia, physical diseases, and also autism, mental retardation. And because that they are challenging in communicating, they may be exhibiting such aggression. And finally, in unknown etiology, as per the information taken, we have to shape our intervention. This is all what I wanted to inform.